Ladies and gentlemen, good afternoon on Remembrance Day. This is the second of a series of Gloucestershire Live Facebook sessions about the future of Gloucestershire hospitals. My name's Ian Mean. Some of you may remember that I used to edit the newspapers here for the last 10, 15 years, and also in Bristol. I'm not attached to hospitals, but I am proud to be the voluntary chairman of our organisation committee here. What I'd like to do before we start is introduce the guests. First of all, Deborah Lee. Big wave, Deborah.
Hi, Ian. Nice to be back.
Deborah, proudly wearing her poppy, is the CEO of Gloucestershire Hospitals Foundation Trust. And also welcome Ian Shaw. Ian's consultant gastroenterologist. Welcome, Ian.
Hi, everyone. Thank you. And
also a very important lady here, Honor Govan. Now, Honor is one of our new registered nurse associates. It's her first job. Welcome, Honor.
Hello.
Hello. Now, after last week's session, we were absolutely astounded, Deborah, weren't we, to see that we had tens of thousands of people who were engaged in this broadcast. This is all about the future of our hospitals. We all know there's been campaigning by some people about that, but this is about the vision for the future. What do you want for your hospitals? What are the important services to you? So I just want to ask Deborah, it's Remembrance Day today, the 11th of the 11th. I know you've had a service this morning, Deborah, in the atrium at Gloucestershire Royal. Can you sort of relate Remembrance to the situation we're in now with COVID?
I can, Ian, and in fact I did this morning when I stood out on the grass at the front of Gloucestershire Royal. It felt an incredibly poignant moment, and I was heartened by just how many colleagues came and stood in remembrance of those that gave their lives so that we could do that today. But as you said, one could not help but draw the analogy between the service that I believe my colleagues are giving to their country now through this pandemic and the service that our families and communities gave in the last two world wars. So we did recognise what might feel to some like a degree of irony. We ended on a really special moment, which was to just reiterate our hopes and prayers that nobody in service to the pandemic gives their lives in that service in the way that they did in those early wars. We were very lucky, weren't we, in Gloucestershire Royal Hospitals last time. We had some staff, some colleagues who were very poorly, but thankfully have all made a recovery. So yeah, it was a really as poignant a Remembrance Day as I can remember.
Good, thank you. Now, this Gloucestershire Facebook Live session's going to be split into two parts. First of all, COVID we're going to talk about in the first part. And in the second part, we're going to talk about gastroenterology and developing a centre of excellence for that, rather like oncology in Cheltenham. So over the next five sessions, yes, this is the fifth, we're going to be looking at the future of the services. So today, gastroenterology, inpatient services, then acute medicine the next week, trauma and orthopedics, general surgery, and image-guided interventional surgery. Why are we doing this? You need to tell us how you want our services shaped. Yeah. This is not an argument, it's a debate. Yeah. You're the important people. And if you look at the ticker tape going across the screen now, you'll see how you can get involved with the survey. And please help us to help you on that. So what I'd like to do now is ask Deborah to look at the COVID situation. When we talked last week, Deborah, you gave us some figures. We've had some good news this week on vaccine, but the figures you predicted are not good.
Yeah, and I'm going to put a positive spin on some of this. You know me, Ian, you'd expect that, wouldn't it? But and perhaps spin's the wrong word. I think there were some positive things that are underpinning this week's statistics. So I didn't quite have a crystal ball last week, but actually what I said I thought would happen this week is pretty much, on the money. It's what's played out. So let's look at the community first. So we're fortunate. Let's start with the positive. The rates of the virus in Gloucestershire are still about half those of England. So we haven't caught up the England average. So although we've got slight growth still in the community, it's starting to plateau. And of course, we haven't yet got the impact of the lockdown measures. So that, I think, is a really positive place to be. Yeah. And we know that the impact of lockdown is greatest when transmission is modest or low. So we're still in this golden moment of being able to affect change. So I'm really heartened by that. But what we do know that the people that are coming into our hospitals this week were those that were incubating the infection long before we talked about the lockdown, 10, 14 days ago. So our hospitals are the busiest they've been in relation to COVID. You recollect last week, I think my numbers were about 38 inpatients from memory, nobody on critical care at that time. We were doubling about every 10 to 14 days.
Yes.
We're not at 38, we're at 98. So more than doubled in the last week. And in fact, the doubling has occurred in the last 3 to 4 days. Now, that is what we expected. I said that last week, and it's what we're prepared for. A little bit about who is it that's coming into hospital, because I think, again, there's cause for optimism in this. So,
yes, I mean, you say there's cause for optimism there, because actually, I think you've only got 3 people in ITU, Deborah, which, yes, serious, but a situation that you are managing well. What I also want to sort of go into here is your feelings about the vaccine. We heard a lot about the vaccine yesterday. Absolutely fantastic news about it. We should welcome, and it would be good when you can talk to us to give us your feeling about the whole position with the vaccine. And perhaps Ian, could you just come in there, as we've just lost Deborah momentarily. Could you just talk us through about the situation of this surge? Because we've only got 3 people in ITU. We don't know if those are on ventilators, but this is a big improvement, isn't it?
Yeah. Yes, absolutely. And so I think, the vaccine, first of all, on the vaccine front, I think it's hugely exciting. And although I've sensed there's a little bit of anxiety out in the public about the safety of that, obviously it's coming through at pace, but it will be absolutely checked through, and I think gives us a real opportunity. In terms of our wards at the moment, there's 2 things I think that are slightly different this time. We've got different treatments. So since the first wave, we've got the opportunity to use drugs like the dexamethasone that people will have heard about, which is the steroid, and that's undoubtedly helping. I think we're also managing in a slightly different way. So we've got more respiratory support on the wards that we can give, which is giving high flow oxygen and supporting patients without having to put them through the whole intensive care process. So we're managing that more effectively. And I think, yes, so that's clearly better. And the outcomes are looking much more encouraging this time. That's not to create a sense of complacency, because it still can be a very serious illness, and as you say, we have got patients on intensive care, so it's we are watching it very carefully. But I think there are more positives around this time, and clearly the vaccine coming is a great hope to us all, and I think it gives us a real ray of light at the end of all this.
Yeah, Deborah, about the vaccine, I was reading the Daily Mail this morning. They did a poll. And there are I can't imagine why people would not want this vaccine. Their poll said that 7% of the population didn't want it. This is, it's to be encouraged, isn't it, to have the vaccine?
I believe so. I have seen some extraordinary responses to a message I put out myself on Twitter, encouraging people to take the vaccine, and one of which was, why would you want to take a vaccine when 99% of people that get this disease don't die? So people's attitudes are really, quite varied and broad, and sometimes quite surprising and even shocking, I would say. But I think what's most important about the messaging that we've had this week is that we don't yet have a vaccine. We have a vaccine that is incredibly promising, and the reason that we don't have it yet is because of the stringent safety checks that any vaccine needs to go through. So for those that think the risk of a vaccine is greater than its benefits, I guess the really important message is to say that we have, our scientists have rushed through the development of this vaccine, but we won't rush it to market if it's not safe to do so. So we're just in that little bit of a holding pattern, waiting for the safety test to come through. But it's really, really encouraging. 93% of those that had this vaccine were protected against the virus, and thankfully, the numbers that die were small, and they'll be even smaller this time around. I'm sure about that. But anyone that's lost a loved one will know they don't want it to be their loved one that succumbs. No. So yes, and it's not just about saving lives. The vaccine, it's about enabling us to return to a sense of normality, because the masks go, the distancing goes. So for me, the vaccine is importantly about saving lives, but it's about getting the economy rebooted. It's about getting us back to work, back in touch with our friends and our family, knowing with confidence we can have a summer holiday and spend Christmas together next year. It's all that stuff.
Absolutely. I want to just finish this piece on COVID with your clear message, because that message is still very important, isn't it?
Yeah, it is. So a little bit of a public health broadcast here, because I'm not quite sure all the things that Ian said. By the way, Ian, thanks for catching a ball. That was great. Technology, as ever.
Well, so I suppose just balls happen all the time, don't they?
They do. Technology. So what I would just note, again, just linking back to the vaccine, is that the vaccine and the flu vaccine need to be 3 weeks apart. So if you want to have the COVID vaccine, and I believe that very many of you will, and most of us will, make sure you've had your flu vaccine, please. Yeah, we've vaccinated about 2/3 of the county. So there's still some people hanging back. That's sometimes because it's not been easy to get an appointment, but the flu vaccine is back in supply. So please get your vaccine, because what we do know is those that will get the COVID vaccine first are those that are eligible for the flu vaccine, because they are the older people that have got underlying conditions, and also the healthcare workers. So to my own colleagues, get the vaccine. But I just come back to my message of last week, is that we will follow the trajectory of the North if we don't adhere to what's been asked of us by government as part of these lockdown restrictions. And it doesn't feel easy in our place at the moment, with 100 plus patients in our beds. And to my colleagues' credit, we're continuing to operate on cancer patients today and see outpatients and do diagnostics, but we won't be able to continue with that through winter if we don't halt the trajectory of the virus. And that's what lockdown's about. It's about stopping us following the trajectory of the North. And the signs are really, really promising. As Ian said, patients are coming in, yes, but they're not as sick as they were. The average stay is 5 days, not 11. The treatments are working. So there's a lot to be optimistic about. But if we want a normal life, then we need to lock ourselves down for a few more weeks and await the vaccine.
Good, thank you. Now, Ian, you're an expert, you're a consultant in gastroenterology. I did look up in Google what gastroenterology actually was. I won't repeat all that, but what is it, in fact?
Yeah, so it's an often asked question, Ian, and not least by my children. You think I've got a very strange job, but it's basically the medical care of problems with the intestinal tract, but that also includes the liver, the pancreas gland, the esophagus, the stomach. So we look after quite a wide range of conditions. So that includes diagnosing cancers in those areas, so bowel cancer, stomach cancer, pancreatic cancer. Inflammatory conditions like Crohn's disease, people might have heard of, ulcerative colitis, celiac disease, and liver conditions like cirrhosis, either related to alcohol or other causes of liver disease, of which there are many. So it's quite a far-ranging specialty. It has an impact both in outpatients, where we see around about 13,000 patients in the county a year in an outpatient setting. Endoscopy, which is the camera test that we use to diagnose some of those conditions and also increasingly treat a lot of conditions these days. So the things we can do have changed, and we're doing about 23,000 of those cases, of those procedures a year in the county. So huge numbers. And I mean, since I've been a consultant, I started in 2003 here, those numbers have just gone up and up, and continue to rise because of all the opportunities that we've got to diagnose cancer earlier or even prevent cancer these days by some of our screening programs. But also then we have the sort of branch of gastroenterology, which is on the ward. And that's the bit that's affected by this change that we're talking about, because it's really the inpatient part of this service that is being proposed to change. And the patients on the ward tend to be the sicker end of those conditions that I've talked about. So severe liver disease, intestinal bleeding, some of the more severe intestinal conditions like Crohn's, when there's nutritional problems that we need to support with artificial feeding and these sorts of things. So it's a very sort of complex specialty that touches on a lot of areas. And it's
fine. Well, Honor, you treat some of those patients, don't you, in your ward?
Yes, I do.
Can you tell me about the sort of conditions? And also I want to see how you're enjoying nursing.
I love it so far. I honestly, I couldn't be with a better speciality that suits me. It's amazing. The team's been so supportive with my transition. It's been amazing. But the patients that we see under the big umbrella of gastroenterology, we've got a varied age range from 17, 20 and beyond. Such a big range. I know that Ian Shaw just touched on liver conditions. So with that, we can support patients to detox, which can be quite a tricky thing for both families and patients. And we can support them through that. We can recognise any changes and really make a difference to that recovery for them. We also help patients recover from liver transplants. And a lot of patients that come in, they come in with long-term conditions, which can be really, really difficult for them to come in and have to be in hospital over and over again. And we try and make the most out of their experience with us.
Yeah, good. Now, we hear the government often saying, oh, we're going to employ thousands more police, thousands more nurses. But you are one of those nurses, aren't you? You're one of the new cohorts. And, you know, being a registered nurse associate, I know that you've got a great training program there. You've got a great chief nursing officer I've met. Is it really good to be part of the trust and be starting a career with them?
Yes, obviously. It's been, I was umming and ahhing for years about whether to do my nursing, and this opportunity came about, and straight away I thought, how lucky am I that this has been an opportunity to jump on board with, and I really want to advocate the role, and I want everyone to know what we do, and that if you are umming and ahhing about going to university and doing your 3 years, then come and do the nursing associate post. You will learn so much. Placements have been amazing. The support from the trust has been fantastic as well.
Good, that's great. Now, Deborah, you're hoping that gastroenterology will be developed in Cheltenham as a centre of excellence, aren't you? Rather like we've seen oncology, and I've been here nearly 20 years editing papers, and this is now a world-class facility in Cheltenham. So what are the plans, your vision, to do the same with gastroenterology?
It's a great question, Ian, and thank you for the leading, because I am immensely proud of our oncology service. As you said, it is internationally renowned, it's a regional centre, and yet it's local to us. We have hundreds of patients who can't have their care in Gloucestershire. They have to go to Birmingham or Oxford or Bristol because we haven't developed that same model of excellence here in the county. And when I joined the trust, I think it's fair to say that people would have talked about our 2 hospital thing as a problem rather than as an opportunity. So my vision and the vision of my board and the wider wider partnership in Gloucestershire is let's turn that problem, as it might once have been described, into an opportunity by developing a focus. So, we're going to have 2 hospitals in the county. Unless somebody drops $1 billion out of the sky, for the foreseeable future, we've got 2 hospitals in the county. So let's ensure that they thrive and they're the very best that they can be. And our vision is that we will have one of them, Cheltenham General, that will have a focus on more specialists and planned care, like cancer, like gastroenterology, like the orthopaedic operation, the things where you know what's going to happen. You don't want to have the procedure cancelled. You want to see the best, and you don't want to be interrupted. And then another focus at Gloucestershire Royal on the more acute patient, where they need rapid access to tests and diagnostics and CTs and MRs, and the models are quite different. And if we want to get the best, then we believe this focus, and it's not black or white, we're really committed to maintaining, local access for things like outpatients will be on both sites still. Imaging will be on both of our sites. The common things that people need. You'll be able to access an A&E doctor on both of our sites. Cheltenham will continue to have its A&E. But by focusing on this model of excellence, we can specialise scarce resources, expensive equipment. We can attract and retain the very best, and we're already seeing this. We've got people applying to the trust to say, we've heard about this fit for the future. We've heard about your vision for service X, Y, and Z. We want to be part of it. We want to come and work in Gloucestershire. So in a nutshell, we want to be able to attract and retain the best. We want people to get care locally. We want our outcomes to be the very best in Europe, the very best globally. That might all sound like, I don't know, does that sound like a kind of fine but unachievable vision? It's achievable because we've done it in oncology and we've done it in other areas. We can do it. We can do it in something as complex as cancer. We can do it in all these other areas. Really, as you can tell, I'm really excited by this. Really excited.
Ian, is it possible? You're at the heart of this. You're a consultant. Is that dream possible?
Yeah, absolutely. Absolutely, it is, Ian. I mean, I think why gastroenterology is quite exciting in this fit for the future context is that what we're consulting on as part of this process is something that we've actually been piloting since 2018. So in a way, there's already a sort of proven proof of concept here. And as Deborah said there, I think gastroenterology is really interesting because we manage these chronic conditions that Honors described well there, and we manage some acute pathology. So, I often get dragged out of bed at night to manage someone who's got intestinal bleeding, and we'll use endoscopy to control that bleeding. Yeah. But what we've been able to do is provide a model where we have the inpatient part of our service for patients who are staying for longer in Cheltenham, where they benefit from highly specialist ward nursing, focused gastroenterology input that we can do. But we've also provided provision for that acute service to support the Gloucester site as well. So we absolutely cover both sides, but by consolidating our inpatient bed base onto the Cheltenham site, we're using that resource in a way that we can manage those patients very effectively, giving them all the benefits of that really specialist care. And at the same time, it's released some extra capacity to boost some of our outpatients and endoscopy services, which we're still providing all around the county. So we do endoscopy in Cirencester, in Stroud, in Cheltenham and in Gloucester, and we run outpatients at most of the community hospitals in the county. So we're managing, if you like, it's a sort of model that shows we can do all of this very effectively and get the benefit of that centralized ward with all the expertise while still providing the support.
It's a small example, but if I think about something like there's a national accreditation for endoscopy services, and for many years we struggled to get that accreditation because our waiting times were too long. We couldn't offer endoscopy within hours of a patient arriving, and we're accredited. So over the course of this pilot, because of being able to focus our resources and deliver this service differently, we're now a nationally accredited service endoscopy. We're about to chuck in an expression of interest to become a centre for training non-medical endoscopists. So back to Honours, profession, bringing on other professional groups into things that were typically done by doctors. Honours never going to want to leave Gloucestershire hospitals because we can take her career right through to nurse consultant if she'd like it. But as she said,
chief executive even.
Yeah, well, where did I begin my life? Yeah, where did I begin my life? Yeah. on the
Ian,
shop floor.
can I ask you, isn't the model you've just described a no-brainer? Why would you not want to do this?
Well, I mean, we put it together as part of the pilot back in 2018. I think the concerns at the time are around our ability to support the Gloucester Royal site, I think, predominantly, but I think we've shown we can do that very effectively, and our actual input into theirs increased. So I suppose in some ways, I suppose we do feel it is the right model, and I think that, you know, we very much hope that we can, you know, persuade the public of the merits of that and get support for what we're doing. I think it's just trying to explain the sort of complexities of what we've done in the way we've done it and the real benefits. I mean, in terms of the Centre of Excellence model you described there, I think, you know, again, we have got some real expertise in the county. We were one of the first national training centres for endoscopy. Deborah's described how we're rolling that out to non-medical endoscopists, but for doctor endoscopists, we were one of the first centres to train endoscopists. We've had the national lead for endoscopy as one of our consultants. The national training lead for endoscopy is one of our consultants. I was the national lead for inflammatory bowel disease at the Royal College of Physicians. So we have got a real expertise amongst our staff, and, you know, other colleagues who are trailblazing in other areas they're doing. So I think, you know, it's harnessing that ability to have the critical mass of the trust that serves such a big population, and we can really deliver services that really are not able to be provided outside of big teaching hospitals, really. So we've got that real opportunity to harness that by sort of pooling our resource in the way we're describing, by centralising.
If I'm coming, because I think, you know, it's a really difficult one, this, isn't it? And I do recognise that. But I think in trying to be everything to everybody and have everything everywhere, what we've actually allowed is for services to fall behind. And in thinking that we've been helping the public by giving them everything everywhere, we haven't. And we haven't been helping our staff either, because that brilliance, that excellence that Ian's described, you know, we've almost, you know, for a couple of decades, you know, been making it harder for them to do such an excellent job. And Centres of Excellence is about making it easier. It's about an enabler. So those amazing people can fly even further. You know, we can, you know, our reach can go even wider. You know, if I get brought into Gloucestershire, I don't want to go to Birmingham or Bristol for a procedure that Ian could do because he hasn't got the right bit of kit in the right building. That's not what I want for me and my family.
No. And what would be good for people listening and looking into this is Ian to tell us about their experiences, because I don't think people really understand all the facets of gastroenterology as you've explained. You know, bladder, pancreatic, the whole situation. So, you know, I think this is important. And Deborah, you can't have all the talents in one place, can you?
Well, I'm not sure if I've understood your question.
You can't have every specialist on
everywhere.
One site.
No, and you know, we as I said, if somebody dropped £1 billion out the sky, I could build you something and put everybody together. But that's not here now, is it? I know there's a nod to it in the 2050 plan, and I'm grateful for the nods. But we're trying to make more than the most of what we've got, because that sounds like, you know, trying to make the best of what we've got. We're trying to do better than that. You know, I talk to colleagues up and down the country who would die for 2 hospital sites in their trust. You know, this stuff we're doing at the moment with our, you know, green site, as we call it, and our you know, our hot site, they would die for the opportunity to deliver care in the way that we're about to do in Gloucestershire if we get public support. And I think the only reason we're having this debate, Ian, let's just name it, is because people have concerns about the future of Cheltenham A&E.
Yeah.
Nobody that I have spoken to has been unprepared to travel 8 miles for a better outcome. To save their limb, to save their life, to not have a stoma, to be cared for by a specialist. You know, this is in danger of becoming about something else. So I'm really grateful that we've named that we've been able to give assurances about the future of A&E. You know, and even now, despite the temporary changes, I know it was a question that came in earlier from a viewer. 80% of those that were cared for in Cheltenham pre-pandemic can still be cared for in Cheltenham. This is a small number. This is 15 or 20 people a day who were asking to be cared for 8 miles away, so that hundreds of others can get access to this model of excellence. I think it's a reasonable ask.
one of the questions that came in was from Eve Westwood, who says, taking your point, when is our Cheltenham AE opening full time again, with a perfectly good hospital being left not used to its full use? What you're saying, that is incorrect.
Every bed in Cheltenham is full. It's a busy hospital. I think probably Honor could speak probably at great length about how busy her particular ward is. So it's serving our community really well. But in asking people not to enter our two campuses through the front door of Cheltenham, we are preventing the spread of the virus that would mean that Honor and Ian couldn't do their jobs. They couldn't do their endoscopy. They couldn't do their CT and their imaging. So yeah, we are asking people, local people, to make a bit of a sacrifice, but for a much greater cause. You know, we are operating in Cheltenham today. My colleagues in Bristol and Birmingham are not. It's as simple as that. Yeah.
And Ian, you've been in Cheltenham for a long time. You're building it. You've got a national reputation. Why do you think that some people don't take this on board?
I mean, to be honest, I think it is, as Deborah said, I think most of the anxiety has been around what will be left at Cheltenham. And as I say, I think for us, we've shown a really good example of how we can use the two sites, Cheltenham and Gloucester, in a way that maximises the service. So I think it's, you know, we've moved our main base to Cheltenham, but as I say, we still support Gloucester, and we can get those mixes right. So I think it's that anxiety, it's the change, it's slightly complicated to explain because we've impacted on parts of the service, and the headline message might be gastroenterology moving to Cheltenham, but if you're an outpatient or you need an endoscopy, you can still very much have that in Stroud or Cirencester or Gloucester. So it's trying to get that across. And I think this opportunity is really helpful to be able to spend some time getting behind the headlines a little bit more and just talking that through. So I think my experience, when people understand what we're talking about and they have a chance to listen to it, they engage with that and they do absolutely see the logic. And I think the clinical staff are very much wedded to this and have been for some time. And I think it's been a frustration that we've not been able to communicate that so widely. And I think this is a really exciting opportunity. So thank you.
Ian, I might be doing the public a disservice actually, because as Ian said, when we go out and about and we talk to people, or we do it via Zoom or whatever it is these days, and we spend the time to explain and to listen, you know, we've got an incredibly, you know, articulate and understanding population. And when we have those conversations, as you said, it's a no-brainer. They actually wonder why we're in the room trying to persuade them. But of course, what we have is a small minority of voices who become the loudest. And that's what we're trying to address with this consultation, is to ask that everyone expresses their views. Please, those of you that are passionate about Cheltenham's A&E, keep being passionate. You know, that matters to you, and it's here to stay. But we need the other voices as well, because they if you're a gastroenterology patient, you know, you want this model. You know, you do not want to go back to the way it was.
No, and I think that's a good point to end on, Deborah. Next session, next is acute medicine. That's on Wednesday, the 18th of November. And in the meantime, you see the ticker tape across the screen. Please send us questions. Doesn't matter how difficult they are. I'm an independent person. I'll ask Deborah and Ian difficult questions. These are your hospitals.
You will. You do. You have.
Let's remember, this is Remembrance Day. For me, that's very important. For the people of Gloucestershire, our health service is absolutely important. It's the largest employer in the county, does a brilliant job. That's my view. Thank you.
Thank you. Thank you, Honor. Thank you, Ian. Have a good day.
Yeah. Thank you, everyone. Thank you.
Yeah.